Good morning. Thank you very much for having me. It's my final talk in a series of 4 talks I've given over my time here. Just to remind you, I've chatted about gastrin-releasing peptide in renal cell cancer, into the surgical management of high-risk prostate cancer, and a little bit on targeting the IGF-BP2s in advanced prostate cancer using novel antisense therapies. And of course, this is the natural pinnacle here. It's just the optimization of intravesical chemotherapy. So what it is, it's actually based on a paper that Homey and Peter Black wrote, and they've allowed me to discuss a lot of what are the key findings. And as I was one of the co-authors, I found it fascinating actually that there's lots of new technologies that are coming out with regards, or new techniques for optimizing intravesical therapy that I think are things that we're going to see more of, because there was only 2 things I was sure of before I came to Canada. One of them was that chemotherapy had a relatively limited role in high-risk bladder cancer. And the second thing was that you all spoke a little bit funny. You're probably wondering what I'm talking about, so I think it's time to crack on and talk about the objectives. We're going to talk about what's the role, why are we not using it to its optimal, and what can we do to improve it. So a little bit of background. Bladder cancer is relatively common. It's more common in men than women, and we used to think that this was due to smoking, because men were more likely to be smokers when they were younger. But in fact, now that the smoking rates are pretty much evening off, we're still seeing a preponderance of men, and there's probably some genetic factors as well that are causing this. Its median age of diagnosis is people in their 70s, although obviously we see people a lot younger. Just recently seen a couple of people in their 20s and early 30s in the clinic who've had bladder cancer. 2/3 are superficial, meaning non-muscle invasive bladder cancer. And this really also includes obviously invasion of the lamina propria, and really the distinction between T1 disease, which invasion of the lamina propria, and muscle is one that's argued and debated widely. The key to bladder cancer really is that it really has a very high chance of recurrence, and it has a low chance, or moderately low but still significant chance of progression. Around 50% of patients who undergo TURBT alone will recur within 2 years, and in fact if you take this out to 5 or 7 years, you're getting recurrence rates of about 70 or 80% if you were to do no other treatment. That's why there's lots of research has gone into trying to reduce that number. And we found that so the current intravesical therapies can reduce that by about 1/3 in the long term, but can we do better than what we've got so far? One of the key things when you look through the literature on bladder cancer is that it's evolved a lot in the last 10 years. So when you look back at old scoring systems, and I remember when I was studying for my exam, I'd memorize this and put them into their risk categories because of it, that things are changing quite rapidly, because this risk table from the EORTC, which was published in 2006, is based on studies that, for example, may not have had a redo TURBT, which I'll talk about, may not have involved a dose of post-op Mitomycin C. So it's very hard to extrapolate these results into what we see in modern practice. So in fact, the EOU just this year have updated their risk categories to simplify it. I think it's a great advance, because it makes it very simple to make sure we're all talking about the same thing when we're talking about high risk and low risk disease. So low risk has to satisfy all the criteria of what we know from the previous table. So it has to be primary, has to be a solitary, non-invasive, has to be low grade, small, and be no associated CIS. High risk patients are those that we'd expect, though it's invading the lamina propria, it's T1 disease, high grade or CIS, and then basically they've defined intermediate risk as everything else that's in between. So as I've mentioned, got to be careful, because we have to look at re-TURBT is something that's advanced in the last 10 to 15 years. Post-op Mitomycin C is something that's been around for only about 10 years now. And obviously the importance of maintenance therapy has really come out in the last 10 years as well. So just to touch on a couple of those, because I think it's important to make sure that we don't underestimate the significance of these advances when we're talking about how we're going to optimize chemotherapy down the track. So what we want to see is a little bit of muscle, or what we want to hear or see written down from the pathologist is that we included some muscle in the specimen, and this is what they're looking for. It's the single most important factor on recurrence, and it's one of the most important factors with regards to prognosis. What you'll find is that those that go on to have a second TURBT is that, depending on the study, around 1/3 to half of patients will still have viable cancer in their repeat resection. Now this varies a lot by institution, so you'll find institutions that were part of EORTC trials that have very experienced endoscopic surgeons. In fact, their rate of disease in the repeat resection is only around 10%, but then other centres will have disease rates of around 50%. And as you can see that if you do go back and do a second TURBT, we have these results showing at 12 months you can halve the rate of recurrence in the short term by doing the second TUR. And in fact, those that go on to have T1 disease from non-invasive disease can be around you can get it down to 6.5%, whereas in some studies they've been as high as 23%. Now, one of the key things, what Dr. Gleve's always told me, the key to any study is really the control group. So you've got to look, in a lot of these studies, you've got to look, is the control group what we'd expect? So when you look at a study like this, you look at the single TUR rate, and a 23% progression rate is actually quite high, and in fact the average is probably around 10%, and so you can get it down to 6.5% at least in this particular study. But you can only compare patient populations within the one study, and that comes up a little bit when we go through the different studies. Those who like it in pictures, we can see that a lot of the benefit from the second TUR is attributed or experienced in the first 24 months, and after that, and that's really what you're looking at, is regrowth of that tumour that you've missed or reimplantation. And in fact, once you get past that, obviously you're not affecting the field change in the bladder, so you can see the curves don't spread once you get past about 24 months. The next biggest advance probably with regards to chemotherapy in bladder cancer is the use of the single instillation of Mitomycin C. So we have a meta-analysis, and this really is what changed our practice in this regard. We looked at 7 trials, there were almost 1,500 patients with a relatively short follow-up of only 3.5 years. But as you can see from the forest plot here, you see that the vast majority of people that gave the post-op dose of Mitomycin C as compared to the TUR, in fact they found there was an improvement in the recurrence rate. Now this recurrence rate improvement was found really only in the first 500 days, and after that the curves level out, and this is in the meta-analysis. And as we said, we're talking about the risk of reimplantation in this case. This is another thing that comes up, the importance of the induction versus the maintenance therapy in bladder cancer seem to affect 2 different things. Now, what we found was an absolute reduction of 11.7%, so the number needed to treat is 8, so 8 chemical installations to prevent 1 recurrence. Now this is not just the case for Mitomycin C, and in fact the meta-analysis looked at different intravesical chemotherapy agents. And what we found is that they were all approximately equally effective except for thiotopa. But this is significant when you consider Mitomycin C is about 2 or 3 times the cost and seems to have a shelf life, according to pharmacy, of about 7 minutes. So the 2 types of intravesical therapy that we have are BCG, which is an immunotherapy, and obviously chemotherapy, of which Mitomycin is the key one, and there's others which I won't really be talking a lot about today, as we'll have enough time focusing on Mitomycin. So to understand the benefit of Mitomycin C, or where it may differ, we have to understand BCG. The bottom line is we don't really know how it works. What we do know that it does is that it is taken up by the mucosal cells of the bladder, the urothelium, by a fibronectin-dependent mechanism. The urothelium releases cytokines. The urothelium also has dendritic cells that pick it up and present it to either cytotoxic T cells or T helper cells, which release more cytokines and stimulate the activator cells such as natural killer cells, macrophages, or in this case the cytotoxic T cells again. So this seems to be one of the key mechanisms by which it works, but overall if you block any one of these mechanisms, it's still effective. We're not entirely sure the complete effect of how it works. Mitomycin C is different. It's isolated from the broth of a bacteria. It's an alkylating agent, and what it does is, within the body, it's bioreduced, it's aromatized. And what it does is get in the cells, and it causes DNA cross-linking, which then prevents all the necessary cellular processes, such as protein or message RNA transcription, and stops all the production of the proteins and those things necessary for cellular life. Importantly, and why it's so useful, is it does have a large molecular weight, so it has very little systemic absorption. Now, the efficacy of BCG has been well proven. There's plenty of studies, but to get the baseline, we need to know what it does. And what we have is a 2002 meta-analysis looking at 24 trials and over almost 5,000 patients, which has shown the benefit of BCG to be the equivalent of around a 28% reduction in recurrence. So we can get that, in fact, and this is what I learnt from my exams when I was studying, was that BCG reduces recurrence by around 40%, reduces progression by around 27%, and you compare that to Mitomycin C, which has no effect on progression but reduces recurrence by around 15%. So I should have probably said that earlier. So that's where I was starting from when I thought, what's the point of Mitomycin C benefit or therapy? So what we have here is, and this is really the key paper, but you can see the absolute benefit's actually quite small on progression in this case. It's actually down from 13.8% down to 9.8%. And the key to that is really that you've got to think it's very toxic, and the side effects of BCG can be very high. When you consider that around 1 or 2% of people will have a BCG sepsis, nearly everybody's going to have some sort of systemic unwellness, and as it stimulates a flu-like illness, hematuria and infections that they can get. So for a 4% absolute benefit, you're going to think BCG is pretty toxic on the body. There were some criticisms with this meta-analysis, and there was a relatively short follow-up of the studies that were examined. So some other meta-analyses and phase 3 studies have come out. We look at the one from Sylvester in 2010, and this is one of the key studies that really set BCG as the gold standard, apart from meta-analysis. But we've got long-term follow-up of 9.2 years, and it looked at epirubicin, so any chemotherapy versus BCG, and there was another trial looking at BCG and isoniazid. But really just looking at the two key arms of chemo versus BCG. And what we found was the BCG arms had improved delayed recurrence, rate of distant metastases, overall survival, and disease-specific survival. And this is what I think led to our belief that chemotherapy was an inferior agent for superficial bladder cancer. But interestingly, in this study, they found no difference in progression. So it starts to get confusing as to, well, what's the underlying benefit here. But if we look at the rates of recurrence, you can see the recurrence in the chemotherapy arms about 50%, as we can expect, so no treatment, 80% down to 50% at 5 or 9 years in this case. BCG brings it down to 36%. And the progression rates are relatively similar. Once again, we see that 8.6 to 6.8, but not statistically significant. But even when they're not significant, there's still, BCG always seems to be superior. And if you put it across enough trials, the trend, I guess, makes a bit of an argument. So there was an individual patient meta-analysis, so where they get the data for every single patient and plug it into their own system. A little bit shorter follow-up of 4.4 years. And what they found was that if you used Mitomycin C with maintenance and compared it to BCG, you found some relatively interesting effects. First of all, they found that there was no statistical difference in the progression rate or the recurrence rate between the two treatments, but together they both caused these reductions of 43 and 12% respectively. If you look at the forest plots from this meta-analysis, we see an interesting thing. That is, BCG with maintenance compared to chemotherapy with maintenance improves the time to first recurrence. In fact, if you give BCG alone without any maintenance and compare it to Mitomycin C, in fact they do worse. But in this case, all the arms or the studies that had Mitomycin C received maintenance treatment. So you can see that Mitomycin C with maintenance is actually giving an improved benefit from what you would expect if they had no maintenance, which is really what's happening in the BCG arms. We see an overall improvement, although it wasn't statistically significant, in time to first recurrence of about 10%, but that's including a lot of studies that didn't have maintenance, so in fact it's more around 30%, I think. So 32% reduction if you have maintenance, and I think this is where BCG sets itself as the gold standard for this in this regard. But no statistically significant difference. So we've got a lot of patients, longer follow-up than the first study, in time to first recurrence, progression, overall survival, and cancer-specific survival. And really, this is what had been found earlier, but had been dismissed, I guess, at the time. There was a study in 2004, another meta-analysis. Once again, it was a short follow-up, but essentially no difference in progression rates. This was just looking at progression. So here I was thinking for all this time that Mitomycin C didn't affect progression or was inferior with regards to progression. I think there's a fair number of studies that have come out now saying that may not be the case. We have a randomized trial, and once you look at the 10-year follow-up in this particular trial of in what we would call the SWOG protocol, or optimal BCG induction and maintenance with Mitomycin C induction and maintenance, in fact we see no difference in progression, overall survival, and cancer-specific survival. So I remember thinking about optimal chemotherapy. I think just so we can move on and stop talking about this, maintenance is very important, and this came out in this trial here where we have just induction BCG or Mitomycin C, and comparing to maintenance we see a big improvement in those patients that had the maintenance. We'll get that in this. So I think the key to maintenance, and this is what's come out really, as I said, so the induction treats reimplantation and the primary tumour that you've just resected, and the maintenance is important to treat the field change that you see in bladder cancer patients. So we have a summary, which is that BCG seems to be better for recurrence, and I guess the improved overall efficacy for progression is debatable. In fact, may be essentially equivalent with optimized treatments. So if we're doing pretty well in this regard, surely we can just give more BCG or more Mitomycin C. The issue with BCG is that it probably is already optimized because it's always the balance of risks versus the benefits. So the benefits of BCG we've shown, the risks are the toxicities that we've already talked about. The beauty of Mitomycin C is it's relatively well tolerated. Some people do get a chemical cystitis and that can affect their bladder, but overall they tend to do quite well. So is there a way that we can improve the delivery of Mitomycin C to make it more effective, considering on the base that we're starting from the data that we've looked at so far? So I guess the natural things that we can do to optimize it would be to combine it with BCG. They've got different actions and mechanism. It seems like the logical next step. Maintenance therapy we've talked about. We talk about bladder preparation. I found this is where in the review that we've written with Homie, you start seeing, I mean, there's things here that we just are not doing in Australia. I think it's terrible to look at how poorly we treat bladder cancer with some relatively simple measures that can improve outcomes. We can do more intense or frequent dosing. Chemohyperthermia is one of the new buzzwords around for this. Electromotive drug administration, so EMDA delivery of Mitomycin C, we'll talk about this. We've got combination with other cytotoxics, maybe with non-overlapping mechanisms of actions and toxicities, and combination with novel agents, which is something that we specialise in at the Prostate Centre. And I guess the last thing we'll talk about is that of precision medicine. So are there patients that are not going to benefit from chemotherapy that you can avoid treating, so either which would delay their cystectomy or maybe delay treatment with further course of BCG? And just to knock the combination with BCG on the head, it just doesn't work. There's 5 trials now that have been done that have shown that in fact it has no benefit over BCG therapy alone. Now that seems a little difficult to understand, but in fact I guess the underlying problem with it is that in fact they upset each other. So if you're treating someone with BCG, you want to stimulate an immune reaction, you want all these very metabolically active cells to come into the bladder, which are the immune system, to kill your bladder cancer cells, and all of a sudden you're hitting them with Mitomycin C and you're knocking them off. So you could make, I think that's probably one of the best arguments. I'm interested in what Peter Black thinks as to why the combination therapy, which you would think would work, doesn't appear to. So really the limitations of current chemotherapy are fourfold. It has a relatively short dwell time, which is different to if you give chemotherapy intravenously. You know, it's got a peak concentration of a few hours, possibly a few days, and can hang around for all that time having its positive effect. You've got essentially 2 hours with intravesical chemotherapy for it to have its effect. The drug has to get across a urothelium, which is naturally designed or evolved to not allow chemicals into it. You've got a chemical environment within the bladder, and obviously you've got ongoing dilution with urine production, obviously against the best efforts of our gynecology colleagues who try to stop that sometimes. So the optimization, this is one thing where I really think I feel like I haven't been doing a good enough job. These are techniques that were published 20 years ago of how you can improve Mitomycin C delivery to the bladder. You can increase the drug concentration and keep it very, very concentrated. 40 milligrams in 20 cc. I was doing 40 milligrams in 40 cc. I was chatting to Peter Black, who said it's only the last, was it 18 months or so, that you've gone to the more concentrated delivery system. You can alkalinize the urine. I've never given someone sodium bicarbonate to alkalinize their urine. It should be done the night before, the morning of, and then half an hour before. It improves the action of Mitomycin C as it's less effective in acidic urine. Decrease the drug dilution, something we did do. We didn't let them drink for 4 to 8 hours prior to their preparation so that they're not diluting the drug while you're giving it. Confirmation of bladder emptying. I think popping a catheter in, and people with experience of doing that are usually pretty good at getting the bladder to empty. And then the 2-hour dwell time that we're doing. So the increased drug concentration, alkalinization of urine are 2 very simple things that we haven't been doing, but will certainly change when I get back. And really, when you look at, well, does that make a difference doing this whole technique? And in fact, there was a trial done in 2001 that showed, in fact, if you do these things, and the key to the study was one arm was just standard treatment, 20 milligrams in 20 mils, and no other optimization techniques were performed. And you compared that with 40 milligrams in 20 mils, dehydrated patients, alkalinized urine. And in fact, you can see that even at 5 years, the recurrence-free survival is twice as good if you do the optimized treatment. and in fact the median time to recurrence is quite long. And the important point about this too is that the 5-year recurrence in the standard treatment, considering that this was an induction course only without subsequent management, is about right. So you've got 80% recurrence in standard, which is what you would expect, and you get that down to about 42% where you'd expect 50%. So I guess one thing is how much you're actually improving if you were to put in maintenance therapy as well. So that's one of the limitations of this study, but it's certainly better than the standard treatment we've been doing so far. The next question is, we give it once a week, and you wonder if this was designed by a government employee who only works once a week, or is this because this is what we did for BCG treatment? We know that BCG needs some time to be effective. You can't just keep giving it. Whereas in fact we know from in vitro data that a lot of these cell lines have multiply or have a doubling time of 1 to 2 days. So in fact, if you treat and then wait 7 days before your next treatment, even though it's in vivo, they grow a lot slower, it's a specialised environment, there's no reason or no evidence as to why once a week is the right treatment. So there's only been one study done that looked at treating these patients more often, and they all got 6 treatments. It was just induction, looking at a short-term complete response rate at 3 or 6 months. And in fact, if you give it 3 times a week for 2 weeks instead of once a week for 6 weeks, patients seem to do better just with regards to complete response. It's one study, and it's sort of something that's going to be interesting for down the track. But we really start to move on to the 2 things that I think are really fascinating and seem to be relatively simple techniques for what give quite marked improvements in recurrence and progression. And we're looking at chemohyperthermia here, and what we have here is a picture of the Synago system, which is a commercialized system for delivering Mitomycin C with hyperthermia. And what the theory behind the hyperthermia is that by popping in this catheter with a probe that releases microwave radiation and heats up the bladder and the mucosa, is that you're increasing the cell membrane permeability, you alter the tissue blood perfusion, making Mitomycin C more effective, and you're causing cell stress, DNA damage, and you're able to promote apoptosis. The Mitomycin C is then working in a better environment in that regard. And these are the studies that have been done, and once again, the problem with this chemohyperthermia and the electromotive drug administration we'll talk about in a minute, there's only 1 or 2 places that really do it, and they contribute a lot to the literature and hasn't been taken up widely, although we'll say that there are some trials coming along. So there's been a couple of studies by Colombo and his group. We did a randomized trial. It's a small number of patients. They gave 8 1-weekly, so 8 treatments once a week, 60-minute treatments with hyperthermia, and then followed it with 4 monthly sessions. So it's only 6 months. It's not what we would call optimum maintenance treatment to affect progression. But as you can see, there's quite marked differences in the recurrence rate. So you're getting what standard Mitomycin C without chemotherapy. That's actually probably quite generous with regards to a 2-year recurrence rate of, well, I guess once we get it to 7.5 years, it's 80%. But without maintenance therapy in these patients, you've got a 40% recurrence rate compared to 80%. This is a significant improvement in recurrence from what's a relatively simple technique. Obviously, there was a systematic review was performed. 22 studies. They were largely from the same group when they were able to compare them, but it really is just a pictorial representation of what you can hope for. And what they found was, when they looked at all the studies, in fact, was that there was a 59% reduction in the rate of recurrence when using chemohyperthermia as compared to standard treatment. There was a slight increase in the side effects, but these were not significant between the groups, but it's certainly something that we need to be aware of, as any intravesical therapy is really risk versus benefits. So it's been commercialised, as I said, and there's a couple of large studies ongoing at the moment. There's a study in the UK by Cancer Research UK, and there's the European trial, which I think has finished accrual almost over 2 years ago now. We're waiting for their results. But this is really what got Amy and I interested in it, and that is that Peter Black is a real advocate for this electromotive drug administration. Now, when he first told me about it and asked me if I could do it for some of his patients, we had a discussion regarding, is it really going to make a difference? And he was very, very enthusiastic, and that piqued my interest. I thought, well, what's actually going on? And so what we have is you have a catheter that goes into the bladder. You put some electrodes on the patient's abdomen. And what you're doing is creating an electrical field across the tip of the catheter and these electrodes. So it's positive in the bladder, it's negative on the electrodes. And this has 3 supposed effects that can improve the efficacy of Mitomycin C. So you have these three mechanisms, which I had to look up on Wikipedia: iontophoresis, electroosmosis, and electroporation. Iontophoresis is driving a positively charged particle across a membrane or a tissue using the electric field. So you see this, they often use this for skin treatment administrations. If they want to drive, you can positively charge your drug, put it on the skin, drive it into the skin. In the bladder, this seems to work. And what that causes, if you get positively charged particles moving across a field, you'll get other non-charged particles that will follow. Now, mitomycin C is positively charged. It will move across its field. It will be dragged across the same field by other charged particles. And what you see is that, remembering that cells, that the membrane of cells is an electric field where the proton pumps and the sodium potassium pumps are keeping an electrical field across the actual cell membrane. So if you can disrupt this, they become more porous, and the mitomycin C is better able to get in. They're the three mechanisms. Does it actually work? They don't have to hang around for as long, or they don't have to keep it in their bladder for as long. And there's really only one large group in the UK that's been doing this, and they've got some very, very impressive results. If you look at the complete response rate at 6 months, when you're looking at the EMDA versus the passive mitomycin C, you get response rates of about 60% for EMDA and only 31% for mitomycin C. Now, one of the key things here, though, thinking of what is your control group like, in fact, a complete response of 31% is actually quite low, even for standard MMC. But it's at least equivalent to BCG at complete response, but that's maybe what you'd expect anyway. Median time recurrence was improved in EMDA as compared to BCG. So then they've looked at other things, which is alternating BCG with Electromotive mitomycin C. Remembering that mitomycin C and BCG don't work when it's standard mitomycin, but doesn't make a difference if you use this technique and you space the treatments a little bit more. And in fact, what you find, and this used maintenance as well, with a 7-year median follow-up, we've got quite significant improvements in disease-free interval, recurrence rate, progression rate, and cancer-specific mortality. Once again, the proviso always been looking at the progression rate in BCG. Now, while it was a very high-risk group, you're still looking at 21%. You wonder, is this really a good standard control? Larger trials are required. But this is really one thing that I think it's really very significant, and that is the use of peri-operative EMDA. One of the key restraints of the single-dose mitomycin C is that it can't be given to patients that have had a perforation or a suspected perforation. So we looked at one study, 400 patients, median follow-up of 7 years. Some had EMDA followed by TURBT, others had TURBT with a standard single installation of mitomycin C. You can see, in fact, the EMDA had a better effect on recurrence rate and also a longer disease-free interval. And that really will do away with a lot of the discussions that you can sometimes have with the attendings as to how your operation's gone, and everybody can get the treatment. So another chemotherapy agent that we use is gemcitabine. We have similar efficacy in intermediate risk patients, less efficacy in high risk patients, and the gemcitabine, this is really where the chemotherapy, it's got to carve out more of a niche. In BCG failures, it's better to flick to mitomycin C than to give ongoing courses of BCG, and it's superior in this regard. We look at other things such as combination with other cytotoxic, and this makes a lot of sense if they have different mechanisms of action. Mitomycin C is a desiccant. Other non-desiccant cytotoxics would be gemcitabine or docetaxel. This has not really been looked at in any significant trial so far. We're obviously always interested in the prostate centre, or the prostate and bladder centre, as Peter Black's trying to get the name changed to, of combination with novel agents. We have preclinical studies looking at herpes simplex viruses, histone deacetylase inhibitors, inhibitors of other growth pathways such as the fibroblast growth factor, and we also obviously have the heat shock proteins and targeting these with novel antisense therapies. In fact, we have a phase 1 trial running looking at OGX427, which targets heat shock protein 27. It's a phase 1 study in bladder and superficial bladder cancer. So I think we've really finished with, these are the current techniques that people have looked at to try and optimize the current mitomycin that we have. But as we move into a world of what you'll hear this word more and more, precision medicine, which is where can we, from the genetic makeup of somebody's cancer decide what treatments are going to suit them best or be ineffective. It's one of the key problems with, say, key arguments against neoadjuvant chemotherapy in muscle-invasive bladder cancer is that some people won't respond, they're going to progress, we've missed a good opportunity to treat them earlier. If you could predict who was not going to respond, then that would be a wonderful advance that would benefit everybody essentially. So this has been looked at in superficial bladder cancer. And I've looked at several genes. We've got the multi-drug resistant associated proteins. We've all heard about these. They pump the drug out of the cells, particularly relevant when we're looking at intravesical treatments. I guess, with intravenous treatments and intravesical, it can still happen. But what we've found is that when they've done these trials where they've done TURBTs, looked at these particular there's just this particular gene, which is the P glycoprotein encoded by the MDR1 gene. In fact, there was no association between its expression in the TURB specimen and their response to intravesical treatment. Another mechanism of chemoresistance is the cell adhesion-mediated drug resistance. This is the cells are naturally connected to each other and to the extracellular matrix by fibronectin and laminin, and these provide some sort of resistance to chemotherapy agents. And in fact, once again, this has not been looked at, but there's another mechanism we can look at is the expression of these in the tumours affect their resistance. But what have been, there's two systems that have been looked at to see if we can predict people's responses. And we've got one group of researchers that have looked at the chemosensitivity profile and the genetic apoptosis resistance profile in people's primary tumours, and then tried to base it on whether or not they'd respond to chemotherapy. And what they found was a small number of patients, but they felt that they could accurately predict their response to chemotherapy in 96% of patients, so 34 to 35 from the chemosensitivity profile, and 80% for those in the genetic apoptosis profile. It's a small study, but this is the first steps toward precision medicine we're going to see. And then I think the last thing is the Coxon model, which is where from the NCI-60, which is the panel of 60 standardized cell lines for bladder cancer, or in fact any cancer, looking at genes that may give resistance to chemotherapy agents, they've come up with a signature cell database. And in fact, what they've found is that they're starting to look at this in cancers, and I think we're going to see more of this as time moves on, as the expression of these particular cell signatures and how they affect cancers. But once again, there's no studies in this regard. It's one small study, but we'll see more of it. So in conclusion, these are the steps to optimising our management of Mitomycin C, just moving away from the chemotherapy, really is the importance of a good TURBT and a single post-op installation of Mitomycin C. Now, the role of the Mitomycin C is slightly controversial. The EAU guidelines say we should be doing a second TUR on everybody who's high or intermediate risk. The AUA guidelines say you can probably avoid it in some people with intermediate risk if you feel you've done a good resection, single tumour, no associated CIS, even if it's high grade and there's no T1, then you're probably okay. AUAU say go back on everybody. Risk assessment, just be aware when we're looking at old studies that they haven't been optimised according to some of the basic advances that have been made with regards to re-TURBT, post-op mitomycin, importance of maintenance. Intravesical treatment should be induction plus maintenance, and really we're going to see optimised Mitomycin C making more headlines in the near future, I think. And obviously, really one of the keys is looking at failures, not something we're going to talk about today, but at 3 months you want to make sure you don't have refractory disease or worsening disease or recurrences outside the field of your initial TUR. So thank you very much. It's been a fantastic 2 years. I've even got used to the weather. It's been great to meet you. I really appreciate your thinking and help, and thank you all. Thanks a lot.